Regarding the recently reported findings of the C212 study of Simeprevir in HIV-positive individuals, what advice would you give to clinicians who are managing co-infected patients who have not yet initiated antiretroviral therapy, particularly concerning when to start antiretroviral therapy and which regimen to use?
I think a lot of us think about this now. When you have a new patient with HIV and viral hepatitis, recognizing that ultimately our goal is to attempt to treat both their HIV and then at some point their hepatitis C. If you're going to be starting them on an antiretroviral regimen, then you need to consider the possibilities of HCV treatment and what that treatment would be. In the setting of the C212 trial, which was the phase 3 study of Simeprevir in combination with pegylated interferon and ribavirin for treatment naive, treatment-experienced co-infected patients, I think the big issue there when you're thinking about starting an antiretroviral regimen is that Simeprevir has significant drug interactions because it is a CYP3A4 substrate. For that reason, there are only 3 primary antiretrovirals that you can utilize in an HIV co-infected patient who you want to expose to Simeprevir. And that would be rilpivirine, raltegravir, and in this case in the study maraviroc, which is not a standard first-line treatment. So ultimately, if this is a new treatment-naive HIV patient, you would have to start them on a raltegravir-based regimen or a rilpivirine-based regimen with either tenofovir and emtricitabine or an abacavir lamivudine-based regimen. Those would really be your only 2 options. So I think in that setting, as a DAA, Simeprevir has significant drug interactions, at least moderate, and that really limits the options that you have for antiretrovirals. Moving forward, most DAAs are going to have some interactions. There are several that have few interactions, and therefore you have more options. But ultimately, whether we're really, now that we're moving forward with more DAAs coming, I think we're less likely at this point in time moving forward to start a patient based strictly on the C212 trial. You're really going to start patients, I think, in many ways recognizing that we have a slew of regimens coming, that in large part you could put them on what you think is appropriate for them for their HIV, and then you can pick the Hep C regimen in the next 6 months based on their ARV regimen as opposed to the other way around, which is what we've had to do prior to now.